All right, this is evaluating the lumbar spine. We're going to be covering the key components of a lumbar spine evaluation today. So what I want to preface this presentation with before we get too far into this is that we cannot neglect the subjective interview. And I intentionally made this for you guys to just focus on the physical exam, but please don't forget the value that the subjective interview has and how much information that's going to give us as we go through the evaluative process of our patients with lower back pain. So what we're going to cover today are the key components, and this is, in my opinion, perhaps one of the best ways to evaluate the lumbar spine because it really gives you a ton of information, and that information is going to guide how you go about planning your interventions and ultimately getting your patient back to whatever it is that they want to get back to. So I'll quickly touch on each of these and then go into more detail as we go through the slides here. So we've got repeated motions, functional mobility, we've got a functional assessment, and then we've got the clinical audit process. Repeated motions, some of you may be familiar with this, but this is your mechanical diagnosis and therapy, MDT or McKenzie, however you know it. So we're going to take a look at repeated motions. Functional mobility, we're going to look at keystone regions or the linchpins of our mobility. The functional assessment, we're going to take a look at movement competency and movement capacity or physical capacity, and then we're going to talk about the clinical audit process and how you can use that in the evaluation of a patient with lower back pain. Again, I need to emphasize the fact that this is missing a critical component, and that is a subjective interview. With the subjective interview, we're going to utilize motivational interviewing techniques and make sure we get a really, really good history to help guide this physical exam process, but also develop rapport with the patient and help us plan out our educational interventions as well. All right, so repeated motions, if you're not very familiar with this or very familiar with how I operate, you'll learn quickly that I'm a big fan of repeated motions. So the really nice thing about repeated motions is it gives us insight into our mechanical sensitivity, loading asymmetries, and preferred positions or motions of the patient. So what is mechanical sensitivity? Well, that's going to be during your physical exam, any movement, position, posture, anything like that provokes the patient's complaint of pain. So the nice thing about using repeated motions is a lot of the time you can get some insight into what movements cause them pain. The other thing here with loading asymmetry, this is really another beautiful thing about repeated motions is it tells us what this patient prefers in terms of the directional preference. So what movement do they have a lot of mobility into? What position do they feel good in? Or what movements or positions cause their pain or are significantly limited in mobility. And then kind of tying into that is, what positions or movements do they prefer? Now, just because they prefer something, it doesn't mean it's the best movement for them. And in fact, more often than not, I find that patients will move more frequently into the position that's actually perpetuating the problem, or what I call picking the scab. So that's a great thing about repeated motions. Additionally, it's a great starting point for symptom modification. If you've ever used this clinically, you've probably seen that using repeated motions can take away somebody's pain very, very quickly. And this helps with patient buy-in. And also, the nice thing about repeated motions is it gives the patient something they can do themselves. So a hands-off approach here. And if you're patient with repeated motions, much of the time you will find a directional preference and you will find something that helps the patient's pain start to go away and go away very quickly more often than not. So repeated motions is going to include flexion, extension, and side glides. In other words, we're going to look at somebody doing standing flexion or a toe touch. Oftentimes we'll have them do 10 or do it in sets of 10, and you're really looking for a reproduction of the patient's pain, a worsening of the patient's pain, or an improvement in their pain. And then you're going to take a note of that. We want to make sure we look at all movements. So we'll check it in standing. So they'll do a toe touch 10 times. We'll see how many sets of 10 they have to do before we decide if we need to move on. And then you can check the same thing in lying. And basically the lying flexion testing is lying on their back, pulling their knees up to their chest, and doing repeated sets of 10 with that. Next, we're going to look at extension. Extension in standing is going to be back bending. Again, you'll check that 10 times, do a couple sets of 10, and we're really trying to determine if this changes the patient's pain or their mobility. Oftentimes, my question while they're doing this is, do you feel better, worse, or no different? Very simple. It's no shades of gray. They either feel better, they feel worse, or there's no change. We can also look at extension lying, in which this is your classic prone press up, and then side glides in standing. So this is going to be a frontal plane hip shift the patient performs to assess for a frontal plane loading asymmetry, or to assess if the frontal plane is compromised or causing their pain. This is going to be really good for people who have unilateral back pain, or if you've got somebody who has unilateral back pain with sciatica or radiating leg pain, or they come in and they have what's known as a lateral shift. So that lateral shift is going to be, when you're looking at the patient from behind, their hips are off center one way and their trunk is off center the opposite way relative to the hips. We're going to name that lateral shift according to what the superior or upper segments are doing. So for example, if you're looking at somebody from behind and their hips are offset to the right, which means their torso is relatively shifted to the left, we're going to call that a left lateral shift. Now, after our repeated motions testing, we want to look at functional mobility. So as you can see here, I use the words keystone and linchpin, and I just think that these are really good words to help describe exactly why we're looking at these particular areas of mobility. So keystone is a central principle or part of a system on which all else depends. Now, I don't want to put that much weight on these particular areas of the body and their importance in mobility, but I feel like I really have to emphasize just how important these areas are for good spinal hygiene. So, again, I call these linchpins, mobility linchpins of good spinal hygiene. In other words, something that is vital to an organization or vital to a system. So the thoracic spine, the hips, the ankles, the big toe, these are all critical areas for good spinal hygiene. And I think for the most part this is intuitive, and I think that they're probably talking about this in school. You guys have probably heard this out in the clinic. You probably are paying attention to these areas if you're in the clinic, hopefully. So thoracic spine, we know that it is just superior to the lumbar spine. If you've got a stiff thoracic spine, inevitably you'll have compensatory movement in the low back, which probably won't bode well for pain. Same thing with the hips. The hips should be a mobile joint, and so if those hips are stiff, you will have compensatory movement in the lumbar spine, which the lumbar spine does not love a lot of movement, especially when it comes to rotation. So you want to make sure you've got good hip mobility, notably in the transverse plane. The ankles, another really important area. If you have a lot of ankle stiffness or immobility in the ankles and you're doing functional patterns or functional movements, which we do each day, squatting, split stance, things like that, walking, running, if your ankles don't quite have the mobility they need, that's going to have upstream effects up into the lumbar spine by influencing the mechanics at the knee and the hip, and of course the lumbar spine. And then lastly, the big toe. The big toe with mobility deficits is not as big of a deal as some of these other areas, but it can compromise the lumbar spine. As we walk, run, and do those different activities, we need adequate great toe extension. And if we don't have that, again, we'll see these upstream effects into the knee, in the hip, and then ultimately the low back. More importantly with the great toe is its ability to uptake sensory information and how that can influence glute engagement as well as total body proprioception. So that's why I included the big toe here, but maybe not necessarily key for functional mobility. Probably fall better in my functional exam section, which is next, but I put it in here anyway. So your big three, if you will, for functional mobility screening should be thoracic spine, hips, and the ankles. All right, so the functional exam, this is the next component of when we're, our key components of evaluating the lumbar spine. So our functional exam, what's the goal, right? And really we're trying to identify the low-hanging fruit. In other words, what's the most obvious thing in their movement that we can try to resolve? And that's going to give us probably our quickest return on investment. And so why is this important? Why do we need to find something that can be resolved quickly? Mostly for patient buy-in, but also if we're using a movement-based approach, it starts to show the patient how valuable movement is and how much they can actually do for themselves. Because hopefully when you found the low-hanging fruit in your functional exam, you can prescribe a movement-based intervention, an exercise of some sort that can help resolve that or improve it, or break a thought virus from the patient, or eliminate a fear that they maybe had with that movement previously. So again, in this functional exam, we're trying to find that low-hanging fruit, and we're also trying to find their capacity shortfall. In other words, what is somebody's physical capacity limitations? Okay, so again, let's move down to competency. So when we're looking at movement competency, we're looking at fundamental movement patterns, multi-joint movements that are related to the identified activity intolerances or functional limitations that the patient told us. So again, that subjective interview is critical. If we don't do a good job with that, we don't know what the patient is really struggling with or having a hard time with. So our movement examination should reflect things that are similar to what the patient is having a hard time with. And this does two things. This helps us see why they might be having a hard time with it, but it also builds relatedness. So if I look at a movement and the patient's like, well, yeah, that's a movement that hurts me, and you also find that there's some movement dysfunction involved in it, now you have relatedness. Now it's very easy or easier to help that patient be compliant and get buy-in on your program. The other component with competency examination or screening is looking at our basic training elements, and this is going to include your fundamental patterns of daily living. You guys have heard me probably talk about this before, but squat, hinge, push, pull, carry, single leg stance, split stance, and I guess the other thing I should add in here is either twist or anti-twist, or rotation or anti-rotation. But these are fundamental movement patterns that happen for every person nearly every day. So if you get in and out of a chair, you squat. If you bend over at all, you're doing some form of a hinge. If you need to open a door, a lot of times you're pushing it. If you need to open a door the other way, a lot of times you're pulling it. There's other examples in our day-to-day life as well with pushing and pulling, but definitely fundamental patterns that we need to be able to do. We carry items both unilaterally and bilaterally. We spend periods of time on single leg stance with gait. If you're more athletic, that might involve running. And then similarly, split stance is another fundamental movement pattern in which we have reciprocal hip flexion and hip extension, again characterized mostly in things like gait, running, and different activities like that. So we should be examining these fundamental movement patterns. We should be looking at and trying to build relatedness with our functional exam. That relatedness should be to what the patient has told us about what they like to do, what they can't do, or what they're having a hard time doing. Looking at capacity, this is really a measure of basically somebody's endurance and how physically prepared they are for activity or for life. If you think about sport performance development or training for athletes and strength and conditioning, we're preparing them for the game, and really that's what we should be doing with our patients as well, preparing them for the game of life or the game whatever relevant functional activity they're having a hard time with. And so we need to look at capacity. We need to look at how much they can handle, what can they tolerate, and we need to push that to that threshold a little bit. We need to push them in order to cause an adaptation and get them to progress. So we look at capacity. There's several ways you can look at this, but the most economically friendly and easiest tests to administer are the talk test, or looking at RPE or RIR. So the talk test is really when you're having somebody perform an exercise, you have a conversation with them, and you're assessing whether or not they can maintain a conversation, Are they having to hold their breath? Are they huffing and puffing and really struggling? We want people to have a little bit of a difficult time with the talk test, but they should still be able to talk. Otherwise, they're more than likely doing too much. But what this tells us is that if you're doing something and you're having the patient do a functional movement screen, or you're taking them through an intervention and they can't pass the talk test, that gives you insight into how conditioned they are. If they're doing a single leg glute bridge and they can't have a conversation with you, but they tell you that they like to go hike and run, well, we have a problem. They don't have the capacity that they need. So the talk test is really good to assess that. The other thing we can use is RPE or RIR. So RPE is rate of perceived exertion, and RIR is reps in reserve. So in other words, you're going to ask a patient when they do something on a scale of 1 to 10, how difficult was that? If they're having a hard time with the rate of perceived exertion or RPE scale, you can simply ask them, how many reps do you have in the tank, or how many more repetitions do you think you could have done? And that's reps in reserve. It's not really part of this presentation, but I'll just tell you guys, you want people to be somewhere around a 6 or greater on the RPE scale, or have 2 to 3 reps in reserve in order to cause physiological adaptation and consequently strength, power, endurance, whatever it is you're trying to develop with that patient. I've put this down here. Every exercise is a test. I think this is very important for people to remember, because as you're going through your functional exam, you've talked to the patient. After you talk to them, you should start getting a really good idea of the movements you want them to do from an exam perspective and an intervention perspective. And then you start getting into your exam and you're seeing these things happen. And it's like, okay, maybe they've got frontal plane deficits, or maybe sagittal plane core control is not very good. So you're starting this planning process of how you want to intervene. And maybe you get to the point where, like, okay, I'm done with the functional exam. The true exam, I want to start intervening, so I'm going to start giving some exercises. Well, when you start prescribing these exercises, you really have to pay attention to how they're performed and how they're doing, because these will tell you additional information. So again, every exercise is a test. We should always be looking at these exercises for both movement competency as well as capacity. How well do they do, and how difficult is it for them? And again here, what we're trying to determine is, does what they have match what they need? We need to figure out if they have the capacity and competency to do the things that they need to do or that they want to do. Because more often than not, they don't, and that's what led to the musculoskeletal problem in the first place. We call that underpreparedness. All right, so last slide here, I want to talk to you guys a little bit about the clinical audit process. And this is not unique to the lumbar spine, but I wanted to incorporate this. And this is something that I learned from Craig Liebenson. But basically, it's not too much different than your test-treat-retest model that we learn in orthopedics. But essentially, what we're trying to do is identify the faulty pattern, mobility deficit, or capacity shortfall, whatever the case may be. All the things that you're identifying in your functional exam, your repeated motion testing, your functional mobility testing. We identify what's going on, and then we need to intervene with the hardest thing that the patient can do well, and then retest the meaningful pattern, retest the RPE, retest the RIR, or the talk test to assess their progress. So in other words, somebody comes in and they're showing difficulty on single leg stance, and so we make note of that, and we start to think, okay, they've got frontal plane deficits, maybe it's glute med, something like that. So we decide, okay, we're going to have them do a side plank with hip abduction, and they tell us that on an RPE scale of 1 to 10, that's a 7. It's pretty challenging for them. And we push that. Okay, we make them work through that. We respect their pain, but we have conversations with them around pain and how it's okay to push through some pain. And then after we do that, we say, okay, let's recheck your single leg stance, and maybe now we have more stability, more control. Okay, so that's the clinical audit process at work within session. And sometimes you'll see those within session improvements. It's important that we don't chase those. We're not trying to look like we're giving a quick fix or anything like that, because truly this process of rehabilitation of the spine, or really any musculoskeletal injury, should take time if we're doing it the right way, because we really are trying to build a person's capacity. Yes, their pain will hopefully go away quickly with some of the things that we're doing, but at the end of the day, we need to create a level of physical preparedness that's going to allow them to keep doing what they want to do. So again, that clinical audit process is huge. And again, this is also seen with repeated motions, right? We identify the directional preference, we intervene with repeated movements, and then we recheck their previously painful pattern or their baseline symptoms. And a lot of the times you're going to see that this process works really well. And it not only works well for you as a clinician to check yourself and see what you're doing and make sure that what you're doing is right, but it also gets buy-in from the patient, and it shows them just how helpful our interventions can be, and just how powerful the human body can be with healing, especially during movement. And again, I mentioned this a couple of slides ago, but really what we're trying to do is find the hardest thing that the patient can do well, because that's going to lead to adaptation. If somebody's doing banded shoulder external rotation, and you ask them how many reps in reserve do you have, and they're like, I could probably do 20 more. Well, we're probably not challenging them enough to actually cause muscular adaptation. And a lot of this is taken from the strength and conditioning world. But really, if we're trying to build resilient patients, resilient athletes, develop robustness, and help them become physically prepared for their unique demands, we have to push towards adaptation. And again, that's going to be at an RPE of at least a 6, or reps in reserve of somewhere around 2 to 3, with meaningful functional exercises that take them to that next level. So I'll kind of summarize everything real quick and bring it all together here. The key components of the lumbar spine exam, again, we're looking at repeated motions, we're looking at functional mobility screening, we're looking at a functional exam that looks at movement competency and movement capacity of relevant areas, relevant, meaningful, related movements that are important to the patient. And then from there, once we've gathered that information, and that's all kind of packaged well with a really strong subjective interview, we start to intervene at that point. And really, I think that that's a really strong way to go about rehabilitating the lumbar spine. But more importantly, with the key components I've outlined in the physical exam here, it makes your intervention planning really quite simple, because you have all the critical information you need. And then from there, you can insert your own interventions. You can insert your own systems or methodologies that you like to utilize, whether that's PRI or DNS or any other, Shirley Sarman's exercise principles, whatever the case may be. Once you've got this really strong evaluation and examination down, the rest is easy. From there, you provide interventions and you stick with the clinical audit process. And assuming you're paying attention to the principles that underpin all of this, you should see good progress for your patient. So thanks for checking this out. Give me any feedback. If you guys have more questions, I'd be happy to do another one of these, or give you any other information that you might like to have.